Hello everyone. Hello everyone.
Hello,
Hello, how are you, Doc?
I'm fine, thank you.
So we will wait a bit, 2 or 3 minutes for others to join. Okay.
Okay, that's fine.
Okay, guys. So let's start today's class. I am Dr. Bhashan. Today is the first day of renal module. Okay. So usually the first day of the modules are easy because we are studying anatomy and embryology on the first day. Okay. So today, the questions are easy. I will try to do it within an hour. Okay, so if I did it in 1 hour, so Dr. Ali will be taking with you the microbiology class, some questions from Palmo. Okay, guys. Guys, I was saying that after this class, Dr. Ali will be taking class of Palmo module. Some questions from microbiology are remaining. So he will be doing with you your micro questions. Okay. Are you getting my
Yes,
point?
sir. Yes, sir. Okay.
So today's questions are to the point questions. They will have a big stem, but you will identify questions by some big clues. So we will do it a little bit fast. These are anatomy
So your
questions.
screen is not shared.
Okay, I'm sharing it. So we are going to start. Okay. Okay, guys. Anyone who wants to start?
Yes, a
Yes.
24-year-old man is being evaluated for
Yeah.
gross hematuria.
Sorry for interruption.
Okay,
So we were saying in our previous classes that we will have to start the questions from our
o-
last lines. If you are not in that classes, so I'm gonna tell you again. So we will be starting over from here. So we will know that what are the question asking. We will get the stem easily. Okay.
okay, that's fine. So it says, which of the following is the most likely cause of this patient's hematuria?
Okay.
So a 24-year-old man is being evaluated for gross hematuria. Cystoscopy under general anesthesia is performed. After the
Okay.
scope is passed into the urinary bladder, a triangular portion of the bladder floor formed by the internal urethral orifice and two slit-like openings is observed. Gross blood is seen oozing from one of the slit-like openings. Which of the following is the most likely cause of this patient's hematuria?
So okay. So they are
Mhm.
asking about the cause of hematuria, right?
Yes, sir.
So what is here? Gross hematuria, right?
Mm-hmm.
So we have, guys, you need to be with me, okay? So we have two types of hematuria, right? Gross and microscopic,
Microscopic.
right? Microscopic is present in conditions like glomerular diseases.
Mhm.
So this one is important. And tubulointerstitial. Mostly it is microscopic. Sometimes it can be gross, okay? Are you getting this? So
Yes.
the second important point over here is what's the location of, we need to find out where is the blood coming from, right? So first we have glomerular diseases, right? Then we have tubulointerstitial. Then we have pelvis necrosis, right? I'm coming like in order. I'm going like in order, right? And then we have ureteric, right? Then we have bladder and down below. Okay. So we have after the scope is passed into the urinary bladder, a trigone portion of the bladder formed by internal urethral orifice and two slit-like opening is observed. So we have the openings of, what are these openings? Openings of the ureters, right? So they are talking about the opening of the ureters. Blood is oozing from one slit like opening. So what does this mean? Anyone, please? What does this mean? Oozing from one of
From
the,
above. Yeah.
yeah, great. So the blood is coming from above. So we are here above from somewhere from above, okay? So either the problem is in ureter or pelvis or tubulointerstitial diseases or glomerular disease. So I have told you there will be micro microscopic, right? Microscopic hematuria and pelvic and ureteric will be gross. Below, from below here, most of the time it's gross, and we will differentiate these based on symptoms. Okay, are you getting this? So we will differentiate whether it is gross or microscopic. We will differentiate further based on the symptoms. Like if we have fever and glomerular and microscopic hematuria along with fever, so it's a kind of glomerular disease. We can say pyelonephritis, right? So we will differentiate this based on the symptoms. If we take like ureteric stone, so we will have suprapubic pain, right? Guys, are you following me?
Yes. So you told us it's like hematuria is two types, gross and microscopic. So
Yeah.
microscopic is due to glomerular and tubulointerstitial, and the gross is due to ureteral bladders or pelvis injuries also included in that.
So I was saying that glomerular and interstitial will be micro, right? And below that, most of the time it's macroscopic. Okay. It's not a fixed rule, but most of the time it is like that. Okay. And after that, how will we differentiate this and this? So in macrohematuria, we will look into symptoms. And same over here, we will look into symptoms. Okay. So we will discuss in glomerular diseases further symptoms. Okay, and pathology section, right? And now we have gross hematuria, right? So we are and the location is above the bladder. So that's the stem, right? So now look into the options. So we have bladder rupture. So the blood is coming from above, right? Are you getting this?
Yes.
Yes, sir. Just continue. Thank you.
Yeah. So the other thing is colovesical fistula. What is colovesical fistula, anyone?
Between the colon and the bladder.
Yeah. So we will have air, right? If we have fistula, we will see air bubbles and stool, okay, within urine, along with hematuria, right? Are you getting this?
So
So
that's
the,
like there's a connection between the bladder and the colon,
yeah,
right? Like
yeah, we will
that's
discuss the fistulas in great detail in gastro section, okay?
oh, okay, sir. Thank you.
And the this is the correct option, but let's discuss the others. So urethral diverticulum. So again, it's below. One thing, it's below the origin of the blood, right? Pouring, oozing from slit, right? Are you guys getting my point?
Yes, sir.
So urethral diverticulum is basically an outpouching of the urethra, okay? And it can be visualized when we are performing cystoscopy. So it can be visualized easily, okay? So they haven't mentioned something of like we have outpouching or something like that, okay? So it can be easily visualized. And the other thing is urinary bladder cancer. So bladder cancer have gross hematuria, but sorry, gross and painless. So don't worry about the sign and symptoms. We will discuss each and every one. We will go through urothelial carcinomas, and we will discuss the sign symptoms. Okay. So the only condition we have is papillary necrosis. Okay. Are you getting this?
Yeah, but
So
then for renal necrosis, like shouldn't there be like other symptoms also, like the cast and things like that? And history is not very suggestive of it, right?
yeah, so history is, I have told you in previous class that most of the time in anatomy or questions like this, they won't be bothering you with symptoms and all this stuff. So in anatomy, they are mostly telling you the locations of
Oh,
blood,
okay.
right?
Okay, sir.
So it is, which option is it? Yeah, this one.
So actually, we diagnosed this by the two slit-like openings. The two slit-like opening is the ureters, and some things from the above is coming, right? That's the concept
Y-
behind that.
Yes, yes, you are getting this, yes. So anyone, please?
May I, sir?
Yes, please.
Besides the bladder wall, which of the following structure is most likely to be penetrated by the trocar and cannula during the procedure? A 65-year-old man comes to the emergency department due to severe lower abdominal pain and nausea. He also had been able to urinate for the past 24 hours. The patient has history of hypertension and BPH. On examination, a large mass is palpable in the suprapubic area. Multiple attempts at the urethral catheterization are unsuccessful. An ultrasound-guided midline suprapubic cystostomy is planned. So,
Mhm.
where is the trocar pass through, right?
Mhm. So we
So
have
that's the anterior abdominal wall,
yeah, great.
aponeurosis. Simple.
Yeah, great. Let me explain in very short. Okay. So we have given the condition. I have told you that they will give you straightforward the diagnosis. Okay. So we have benign prostatic hyperplasia, right? So it is causing? He is not being able to urinate. So anuria because of BPH, right? On examination, large palpable mass in suprapubic area. They are asking, they are telling about the urinary bladder. Okay. Multiple attempts of urethral catheterization are unsuccessful. Ultrasound guided midline suprapubic cystostomy is planned. So we are going to relieve the bladder, and we are going to remove the urine. So for this we are performing suprapubic cystostomy. Okay. So the structures, if you have and the some knowledge of the uh, we can say the anatomy. So we have, this is anterior abdominal wall, right? So it's an abdominal wall, right? Mhm. So we have abdominal wall, right? And just after that we will have bladder. Okay, there is nothing in between the bladder, and we don't have any specific organs or something like that between the bladder and anterior abdominal wall. Okay, so why are we doing suprapubic? Bladder is most of the time lying in pubic area, but when it becomes dilated, it goes into false pelvis, or we can call this suprapubic. Okay, so we can
Sir,
do.
can you repeat that again? I mean, the part of the false pelvis, like why do we choose this? Like usually you say that
Yeah, yeah,
we do
most
the
of the time the bladder is mostly in true pelvis, or we can say it is in the pelvis, and the false pelvis is in abdominal cavity. So here the bladder is full with urine, right? So we can access through here. Okay, it's a simple
yes,
point, don't need to be
yes, sir,
mm,
yes, sir.
more
Thank
focused about that. Okay, so
you.
so we have anatomical orientation like that, that we have no specific organs in between abdominal wall, okay, and bladder. So this is the first point, and the other is you can also do the MCQ something somehow like that. We do not want to pierce peritoneum, right? We are not piercing peritoneum for bladder, right? Bladder approach, we do not want to pierce peritoneum because bladder is retroperitoneal. Okay, the only part of the peritoneum, the bladder that is covered by peritoneum is superior wall. Like if this is the bladder, so only this part is covered by peritoneum. Okay, so we do not piercing the peritoneum. Getting my point?
Yes, sir.
So we have excluded B and option E. The ureter, how is the ureter going into the bladder? How is the ureter entering into the
It's
bladder?
obliquely entering obliquely both sides from
Yeah,
the
it's
bus.
yeah, obliquely. Posterolaterally.
Yeah.
So we are coming from anterior side, right? So it's not going to be punctured. Yeah, perineal membrane. What about perineal membrane? So the perineal membrane is part of urogenital diaphragm.
And
We will
perineal membrane will be inferiorly located.
yeah, inferiorly located, and we will discuss perineal membrane in reproductive module. Okay, don't need to be worried about this. All right. So I think we have done with this MCQ. So I've told you first we have to have some orientations of the anatomy, and then you can also do the anatomical questions by exclusion, right? We have excluded because we know that the bladder is retroperitoneal and the other thing is how is the ureter inserting, so it is posterolaterally, right? So it won't be punctured. So the only thing that remains is anterior abdominal aponeurosis. So what is the anterior abdominal aponeurosis? So the abdominal muscles like external oblique, internal oblique, and transversus abdominis, they are ending over here like this, and then we have these ligaments. Okay, this is, let's say this is the linea alba, right? And same over here. Okay, so this is the aponeurosis, and over here it is, I think it is mentioned that we are going midline. I think so. They have no, so they are not saying this, but we are going interiorly. Getting this point, right? So it is anterior abdominal aponeurosis. Okay. Any question?
No, sir.
Thank you. Let's move on. We have, yeah, anyone?
I can go.
Yeah,
Um,
please.
The healthy segment of this patient's transplanted ureter is most likely receiving blood from which of the following arteries? A 45-year-old man with a history of end-stage renal disease undergoes renal allograft transplantation. The donor kidney and proximal ureter are transplanted in the right iliac fossa with implantation of the ureter into the patient's bladder. 6 days following surgery, the donor kidney appears to be functioning well, but the patient developed fever and right lower quadrant abdominal pain. Imaging studies reveal a large pelvic fluid collection. Exploratory laparotomy is performed and discovers urinary leakage with significant ischemia and necrosis of the transplanted ureter immediately adjacent to the site of implantation into the bladder. The proximal portion of the ureter appears normal. So, the healthy segment of this patient's transplanted ureter is most likely receiving blood from which of the following arteries?
So what do you think? Which part is being injured and which part is healthy? Which part of the ureter is?
The proximal part of the ureter is normal, it is saying.
Yeah, so the distal part, necrosis in the
Necrosis.
distal part, and the proximal portion is healthy, right? So let me tell you some important points about ureter blood supply. Okay, anyone knows the blood supply of ureter?
Yes.
Yeah,
The
so
proximal
we
is
will,
supplied by the renal.
yeah, we will go through it together. Okay, so first one is renal,
Yeah.
then this is the abdominal aorta, right?
Yes.
Then we have gonadal,
Middle. Yeah.
right? Then we have the
The right arteries.
common iliac artery, right? Bifurcation of the aorta into common iliac artery, right? And then we have internal iliac and external iliac, right? So what is the ureter being supplied? Proximally, renal artery, right?
Yes.
And distally, gonadal, common iliac, right? Internal iliac and branches of these, right? vesicle, and others, right? So stem is very long, but the question is very simple. They are asking about the proximal portion of the ureter appears normal. Okay, so the
And
receiving
asking for
blood
the
would be,
proximal supply, right?
yeah. So the
That's
proximal
real.
portion, yeah, great. So they are asking about the proximal portion is normal and what is the healthy segments blood supply. Okay, got this. Easy
Yes, sir.
MCQ, right?
Yes, sir. Really?
Anatomy is very easy, right?
No, sir.
It's very easy. You you don't need for
No, sir. It is not easy. You made
Not
it easy,
easy.
sir.
yeah, so I'm saying that you don't need to go into great details of anatomy for step one, right? You only need to have some important high yield concepts, and most of the MCQs are covered from first aid. Okay, so I think the blood supply is also mentioned in the first aid. Okay, so they have given it, I think so, in one line. Okay, so
Yes, sir.
anatomy is easy. You don't need to read all the anatomy. Like I think in first aid, it's only 1 or 2 pages of renal anatomy. Okay, so I was and the other so I was thinking to explain one other important concept of about ureter course. It's a high yield. Most of the time it comes in MCQs. So we have a mnemonic for this water. I think you guys are familiar with this.
Yeah,
Water
water
under,
under the bridge.
what does this means?
Ureter is under the artery.
Ureter under,
The
ureteric,
uterine artery in females and vas deferens in
or
males.
yeah, ureteric, uterine artery, right? Okay, and it is commonly injured in the gynecological surgeries. Okay, I'm not going into detail of that, but they ask you about this. the other important the other important about the course of ureter is first thing, the ureter is going under the uterine artery and over the iliac artery. Okay, over the iliac artery. Okay, so let me make it very clear. So in the course, first ureter is going down like over the iliopsoas. You know that, right? So
No.
over the so don't worry. Just remember the high yield points. Okay. So when ureter goes down, it is going under gonadal arteries, as we have told you the gonadal arteries. Okay. First, it is going under the gonadal arteries. Okay. In higher regions. Okay. Then moving down, it will be going over common, sorry, over, I think it's internal iliac artery, and the last one is under the bridge, uterine. Remember this from you. Water under uterine artery. The last one is more important because it is injured in the gynecological process. Okay, we will discuss this in details in some time. Okay.
So it's the path of ureters, like it follows from, it will go under the gonadal and then over the iliacs and then under the uterine artery again.
Yeah, you got this. Okay.
Sir, quick question, sir.
Under. So first is under, then over, and then under. Okay. Here gonadal, here iliac, and here uterine. Here it is going above the iliopsoas, which is the upper portions, and here it is in the pelvic cavity. Okay. So you don't need to be worried about this. If you want to go or weave this, you can have the a look for the course of ureter. So next question. One please.
Sir, quick question, sir.
Okay.
In the previous question, if the distal portion is normal, what will be the answer, sir?
Yeah. So what is the blood supply of the distal portion of the uh, ureter?
Common iliac artery.
Yeah.
I mean, distal is with the internal iliac and superior vesicle, no?
Yeah. So the middle part is supplied by major artery is gonadal, and some of the branches from common and internal iliac, but the major is gonadal for middle. Okay. And for distal, it is internal iliac, and other branches, the important one is superior vesicle. Okay. So you just need to remember these three arteries. Proximal is supplied by renal, middle is mostly supplied by gonadal, and the distal is supplied by internal iliac and superior vesicle. It's a simple, straightforward question. You need to memorize this arterial or sorry blood supply. Okay. Anyone, please?
Within the true pelvis, the surgeon can most likely palpate the right ureter immediately anterior to each of the following structures. A 40-year-old nulli gravida woman comes to the office with a 2 month history of worsening right pelvic pain. She experiences the pain daily and intensify does not vary during her menstrual cycle. In addition, the patient waist size has increased despite a decreased appetite. Pelvic examinations show a irregularly shaped fixed adnexal mass. 1 week later, she undergoes surgery to remove a large ovarian neoplasm. So, within the two pelvis, the surgeon can palpate the right ureter immediately anterior to each of the following structures.
So what do you think, guys? We have explained this question.
So, that's ureter under the bridge. So,
Yeah,
it's anterior to the iliacs.
Sorry.
It's water under the bridge. So, ureter will be under the uterine artery, but if
Yeah.
they're asking if what's anterior, so that will be iliac, right?
No. What do you
No?
mean by under? Under, under is posterior, right?
Yes.
So above is uterine, and
Yes.
above means here in
Yes.
this case above means anterior, right?
Yes.
So what's the correct option? Sorry. What's the
C.
question again? Sorry, I'm
C.
sorry.
C will be
I,
the correct option, right?
I think I have misread the question. Okay.
Yeah, they're asking about the ureters being anterior to the ureters
Yeah,
will be
yeah,
anterior
yeah.
to the iliacs, right?
Sorry,
And posterior to the
yeah.
artery.
I was thinking they are asking about what is interior to the sorry. You are right. So it is
Internal iliac.
yeah. So you know the concept, right?
Yeah.
So you won't be missing with internal iliac, uterine.
That's total rote memorization. There's no concept in anatomy.
Yeah, you have to memorize this. Like what we can do with the course of the ureter, how is it going, right? And what
Yeah.
we can do with the blood supply, you
Yes.
know. So it's we don't have that much of the concept. Yeah. So don't read the question and just tell me from the CT. What is this? It's very
That's
easy.
a horseshoe
Kidney?
kidney.
Yeah,
That's a horseshoe kidney.
I think 99.99% of the students know this, right?
Yes.
So it's
Very easy.
very easy. And which artery is responsible for blocking it through?
Inferior mesenteric artery, IMA.
Yeah, great. So if anyone wants to read the question,
Okay, I can read that. Which of the following structure is most likely limited the proper ascent of the anomalous organ? 47-year-old woman comes to the office due to fever, dysuria, abdominal pain, had several UTIs since her teens, but no other medical condition. Physical examinations show mild suprapubic discomfort. Urine analysis demonstrated by urea and many bacteria. CT of the abdomen is shown in the image below. So the structure is that's a horseshoe kidney because we can see the lower poles conjoined and the inferior mesenteric artery stops its ascent into the abdomen.
Yeah. So, you guys know this question. It is straightforward, okay? But
Yes.
I'm going to talk about some basic embryology, so it will help you understand other questions, okay? So I will make the embryology somehow simple for you guys, okay? Should we do that or we should move on?
Yes,
We can do
please.
that, sir. We'll do it,
We
sir.
should
Oh,
do that.
okay, okay. So, yeah, guys, you have to be with me, okay? It's very easy, but I am going to make some concepts, okay? So, what's the normal development of kidney? We are developing kidney from mesoderm, right? We have three pronephros. You know that, right? Mesonephros and metanephros. You know that, right? So this one degenerates within 3 weeks. This one persists and forms Wolffian duct, right? In males. And metanephros form the adult kidney. Okay, I am explaining this because some questions they will be asking about the what is the origin of Wolffian duct or what is the metanephros do. So it forms the adult kidney. So the this is the basic concept, and the other after that we learn in embryology that we have two important structures, right? Ureteric bud and
Metanephric mesenchyme.
yeah, metanephric mesenchyme or blastema. You know this, right? So tell me, what does this form and what is metanephric mesenchyme forming? So it is forming parenchyma of kidney, okay? And this is forming the collecting system. This is very high yield, okay? Most of the questions, these points will help you out, okay? So from guys, are you listening to me? Are you understanding this?
Yes, sir.
Yeah.
Yeah. So tell me, what does ureteric bud form?
Collecting.
The collecting duct.
Yeah, so from collecting ducts till ureters, right?
Mm-hmm.
And
Okay.
before collecting duct, we have glomerular structures till distal convoluted tubule. So they are forming parenchyma and they are forming the collecting ducts. Okay, so these were the basic. Now come to important high yield points. Okay, so the we have signaling between ureteric bud and mesenchyme, metanephric mesenchyme for normal renal development. Okay, so if we have if ureteric bud fails to develop, okay, so we think that it will be affecting collecting system, right? guys, right?
Yes, yes.
Yes,
But
sir.
but actually, the important point here is signaling. Without this signal, metanephric mesenchyme or blastema won't be able to develop normal kidney. So, when it failed to develop, when ureteric but failed to develop, we will have renal agenesis. Okay, are you getting
Okay.
this?
Mm-hmm. Yes, sir.
So, I was talking about the signaling is important, right? So, it won't be able to signal the mesenchyme. So, we will have renal agenesis. Okay, so renal agenesis. So, we have, okay, so either one kidney is missing or both, right? Both the conditions are possible. So if one kidney is missing and other is present, so the only kidney we have will it will be filtering all the load, right?
Mm-hmm. A part of
So it will hypertrophy. Okay,
mm-hmm.
and we have the risk of FSGS. We will discuss this focal segmental
Clever.
glomerulosclerosis. We will discuss this uh, after. But you need to remember that this, if we have renal agenesis, we will have hypertrophy, hyperfiltration, and risk of FSGS. Okay. What about if both of the kidneys are not forming? What we will have?
Potter sequence?
Great.
Mm-hmm.
What will be causing Porter sequence? Oligo.
Hydramnios.
Oligohydramnios.
Hydramnios.
So you will have oligohydramnios causing Porter's,
Potter
right?
sequence.
So we are going in like in order. So you will be remembering all the sketch, right? I am going from basic to then development, then agenesis, then bilateral kidney agenesis, then oligohydramnios, then Porter's, right? Getting this right, guys?
Yes,
Be with
sir.
me, okay?
Yes, sir.
So what is Porter's? What's the triad? Be quick. Pulmonary
Pulmonary
hypoplasia,
hyperplasia.
facial,
Oligohydramnios.
and limbs deformity, right? These are the three important IE points. So, more about the Potters. What was responsible for causing Potter's agenesis, right?
Yes, sir.
Why agenesis? Because it is leading to
Oligohydramnios.
oligohydramnia. So, the main reason is oligohydramnios, right? So,
Mm-hmm.
what the, we can say all the conditions which are causing oligohydramnios, because normal amniotic fluid is responsible for the normal growth of the lungs and cushioning of the body, right? So we will have
Mm-hmm.
pulmonary hypoplasia and all that, right? So all the conditions that is leading to oligohydramnios, like polycystic kidney disease, right? Autosomal recessive, right? The functions of the kidney are below normal. It is not forming enough urine, so we will have oligohydramnios and waters, right? Getting my point.
Yes, sir.
So urination, urine formation. First is urine formation. The other is the urine is removed from the body and the baby swallow this, right? This is the normal mechanism, right? So if urine formation is normal, we have discussed in autosomal recessive and agenesis, we have oligohydramnios, right? The formation is decreased. But if the formation is normal, but we have some obstruction in its way, right? Like posterior urethral valves. You know this, right? Posterior urethral valves. So it is present in boys only because it is present in the urethra. Okay. So we have discussed Porter's, and what are the causing factors of Porter's? Renal agenesis, autosomal recessive polycystic kidney disease, obstructive uropathy like posterior urethral valves. Okay, so we should go with posterior urethral valves. Posterior urethral valves. So they are the remnants of urogenital sinus membrane. You don't need to worry about this, but it is, if this is the bladder, this is the urethra, so it is present in the posterior urethra and it is blocking the flow. Okay, this is the posterior urethral valves. Sorry, and it is present in boys, males. Okay, so it can lead to Potters. Okay, the other important concept over here is the posterior urethral valves will cause, they are ureters. Okay, ureters entry, they will cause the raise of here, the pressure will rise. Okay, are you getting this right? Because of the blockage, pressure in the bladder and both the ureter will increase. You know this, right? It's easy concept.
Yes, sir.
Yes,
So this will go back, the pressure will affect kidneys and causing hydro.
hydronephrosis.
Hydronephrosis.
So what is hydronephrosis? Swelling
That's
of
the kidneys.
kidneys. So we are clearing our concepts, some basic concepts, high yield, right? So the what about the horseshoe kidney? Horseshoe kidney. What do you think? What will be responsible for this? Either ureteric bud or mesenchyme. What do you think? Which one is responsible for horseshoe kidney?
I don't think so, either of them, because kidneys are formed, but they're fused from the poles.
So who is responsible for fusing of the kidney?
Mm,
Is it because of ureteric bud or mesenchyme? It's simple.
Is
The
it time?
parent, the mesenchyme, because we have abnormal migration of cells between left and right mesenchyme. Okay, and they
Okay.
will fuse both kidneys. Okay, so what about duplex ureter?
that will be actually ureteric, but
Yeah, so that will be
ureteric,
ureteric,
but
but oh. So they are easy concepts. When we come over to, when we face MCQs like this, so we are trying to memorize this and we forget this. So you guys need to have some simple concept about this. Okay, So let's go to next question. If we have some other points, we will discuss. So what was here? Inferior
Mesenteric artery.
mesenteric arch. This one, okay. Anyone, please?
Which of the following is most likely cause of the infant's presentation? 4-month-old girl is diagnosed with a febrile UTI. Avoiding cystourethrogram shows retrograde urine flow into the right ureter but not associated urethral dilation. 1 year later, avoiding urethrogram is repeated and shows no abnormalities. So, which of the following is most likely cause?
So what do you think? What's the question asking?
Hmm.
What do you
Uh,
get from the question?
they're asking it's congenital short intravesical ureter. The female with short ureter.
So what's the
That's the
problem here?
vesicoureteral reflex happening.
Yeah, vesico-urethral reflex.
Reflex.
We have primary and secondary.
Secondary.
You know this primary secondary reflex.
Yes.
So if it's above the bladder, we call this primary, below
Mm.
secondary. So what's the example of this? Vesico. What's the junction called? Uretero-vesical junction.
Mm.
Obstruction, duplex ureters. They are not well placed, right? So they will be causing vesico-ureteric reflux and congenital short intravesicular ureter. Okay, so it is causing primary vesico-ureteral reflux. What are other important hygiene points about vesico-ureteral reflux?
Sir, can you please repeat this again?
So let's come to the question so you will understand it.
Mhm.
So what is the question asking?
It's okay.
We have a 4-month girl, urinary tract infection, okay, retrograde urine flow
Mm.
into right ureter. Okay, no urethral dilatation. Okay, which of the following is most likely the cause of this presentation? Okay, so we have diagnosed this is a vesico-ureteral reflux. I've told you that the reflux is vesico means bladder, urethral means ureter, and reflux mean urine is going up. Okay, it's simple. So, what's responsible for the backflow of the urine? Either the pressure in the bladder is high, okay, either we have problem in insertion of the ureter, okay, getting my point. So, if the problem is below the ureters, we call this secondary, and called above is primary. So either the ureter in our stem, either the ureter is congenitally short, okay, getting my point, or other condition like duplex ureter. So both are abnormal ureters, okay, and it will cause the retrograde urine flow due to either blockage, or you will see this the short ureter is not anatomically correctly inserting. Okay, so when we, if the insertion is not normal, so when we increase pressure in the bladder, so the urine will go in this direction, but also backwards. Normally, the bladder, so we have the ureter placed somehow like when we increase the forces, when we try to urinate, this valve become closed. So we don't see any upward going of urine. But in case of short intravesical ureter, the ureters are placed like more vertically. Okay, getting my point.
Yes, sir.
So when we try to urinate, the urine goes out as well as goes back. What other condition would cause vesicoureteric reflux? The one reason we have in our option, okay, this one, right? What other conditions? So I've told you duplex.
Duplex ureters.
They are also not correctly placed, okay, and these are the primary. We call this primary
Because there is
vesicoureteral,
above the bladder.
and if the bladder pressure is raised, we will call this secondary vesicoureteral
Reflex.
reflux. Okay, due to abnormally high pressure in the bladder, and it will result in retrograde retrograde flow. Okay,
Yes.
so what about the other options? So in anatomy questions, they will give you options which are easily, we can exclude them easily because they are not related to our stem. So recto vaginal symptoms, something
Yep.
related to rectum, right?
Yeah.
Obstruction due to renal stone.
So that causes
Renal stone,
hydronephrosis.
they will cause hydronephrosis, they will cause dilatation of ureters, but do not cause vesicoureteral reflux. Presence of posterior urethral valves. So the urethral valves are present here. Okay. So it will. So the one most one other important concept over here is the urinary stones will cause hydronephrosis unilaterally, right?
Yeah.
Because we have present this in one ureter. If they are present in both, they can cause bilateral.
Bilateral hydronephrosis.
But what happens in posterior urethral valves? It
They'll
is
cause
present in posterior urethra, so it will increase pressure over
both
heart
sides,
and bladder and affect both
both kidneys. Bilateral hydronephrosis.
kidneys. So bilateral and unilateral. So you guys need to have some concepts of bilateral hydronephrosis, unilateral, different causes. We will explain these, okay? We are taking so much time. I thought to I thought of it to be completed in 1 hour. So this question is from reproductive module. We will discuss this. They are asking about like a patient. So we will discuss this, okay? Don't worry, some question IDs are misplaced. Okay,
Yes, sir.
next. Anyone, please?
Which of the following is most likely cause of the patient's condition? 48-year-old man comes to the office due to a 6-month history of involuntary passage of urine when sneezing or coughing. Recently, she has experienced urine leakage even with normal daily activity, which has been embarrassing and caused a limit to social activities and quit playing tennis. The patient has no weakness, numbness, or fecal incontinence, hypertension, and type 2 diabetes mellitus. The patient had four uncomplicated vaginal deliveries, supine blood pressure is 126/82, and upright pressure is 120/80. Pelvic examination showed normal vagina rugae and physiological discharge. A small amount of urine leaks from the urethra when the patient is asked to come. So that's simple stress incontinence. And
Great.
yeah,
So I've told you these questions are very simple.
um,
Just I
Here's the
am
answer.
going to give you overview about incontinence. So she has been problem of urine leakage,
leakage
right?
and cuffing,
So one is stress, other is urge, and other is
overflow
overflow.
incontinence. Yeah.
So remember it like this. If any stress is causing urine leakage, we will call this stress incontinence, okay? Like coughing,
Sneezing
sneezing,
or
lifting.
increased intra-abdominal pressure. Anything that
Yeah,
causes increased intra-abdominal pressure, right?
yeah, great, great. So any stress that causes incontinence. What is the reason that if a normal healthy patient has increased abdominal pressure, they do not have the problem, of incontinence? So we have, what's the reason?
Urethral hypermobility, actually.
Either the sphincters are relaxed or the tone is decreased, right?
Yes.
And the other is urethral hypermobility. Okay, what's the urge incontinence? So it's sudden, okay?
Yes.
You will feel sudden urge to urinate, okay? And what's the cause of it? The muscles are overactive, okay? The detrusor muscles are overactive, okay? And what's the overflow incontinence?
That always has an increased post-viral volume. Patient cannot
Great.
empty bladder.
So we will have always full bladder. We will have dribbling, right? What will be the causes of this? The
Any
causes are
obstruction
neuropathies like diabetic neuropathy, right?
or BPH,
Yeah, and
any
what's
spinal cord injury, maybe.
yeah, myelomeningocele, or we call it spina bifida in children's, right? So the question is very simple. She has the problem of urine leakage or increased abdominal pressure. Okay. So what's the problem over here is urethral sphincter
Dysfunction.
dysfunction. What is the bladder outlet obstruction? What is this?
BPH can cause bladder out, or any
Yeah,
obstruction can cause bladder outlet.
BPH or
Overflow.
any obstruction, right?
Yeah.
What about detrusor inactivity?
That
What will
can
it
lead to
cause?
overflow incontinence, inactivity.
Yeah, overflow.
Yeah.
And what
Detrusor overactivity will
diabetic
neuropathy will
is
also
also
cause
overflow, and this
yes.
will also causing overflow.
Yes.
And this one is
Urge incontinence.
Urge.
yes. So this is simple concept. Next question is urethral dysfunction. Yeah. Yeah, anyone please? Be quick, guys. The questions are easy ahead. Okay.
CT
We'll
scan of
have
the abdomen and the pelvis is most likely to reveal which of the following injuries in this patient. So we have a 20-year-old man brought to the emergency department after MVC. Blood pressure is 130/84, pulse is 108, respirations 18. The
okay.
airway is intact. Breath and heart sounds are normal. There is a bruising across the central lower abdomen, and the suprapubic area is tender to palpation. Chest X-ray and pelvic X-ray reveals no fracture. Bedside ultrasound show intraperitoneal free fluid. Urine dipstick test is positive for blood. CT scan of the abdomen and pelvis is most likely to reveal which of the following injuries in this patient.
So,
That's easy. That's
what's the
bladder.
problem?
Bladder dome
Something
rupture, yeah.
bladder dome rupture.
Dome rupture, B.
Yeah, so we will discuss, okay? So what is happening over here? What is happening? What do we see? We see
We
intraperitoneal fluid, right?
yeah.
And have some blood in it, okay? And the problem is motor vehicle collision. So why not the other options? It's a very simple question. Why not bladder neck?
Retroperitoneal. Retroperitoneal. This is the
Yeah,
only
great.
intraperitoneal.
So the only part I've told you that is the superior portion of the or the dome of the bladder is being covered by peritoneum, okay? And the fluid is intraperitoneal. All the others are retroperitoneal. So bladder dome, okay? Should I move on?
Yes, sir.
Yes.
Okay. Yeah, we will do this question at last, okay? It's simple. Yeah, just let's do it, okay? I will read it, okay? This pattern of the patients. So this pattern of the finding is best classified as which of the following. So they are asking about the pattern of the disease, okay? So a new boy is being evaluated with the respiratory distress, 37-week gestation, okay? Normal, almost normal time of delivery, cesarean. The mother has limited prenatal care but was noted to have oligohydramnios. Examination of the infant is significant for flattened nose, okay, ear, chin, and bilateral club for deformity. So what's the condition?
Water
Water.
sequence.
What are
What are
symptoms?
sequence?
That's what a sequence.
Yeah, we call this sequence, right?
So that's sequence. Simple.
Yeah. I want you guys
So can we
to,
discuss the other options too?
yeah, great. So what's polymorphism? Anyone, please? So if we have a phenotype present in different form, we call this polymorphism. Like example is height, color of the eyes, etc. So the same phenotype with different presentation, okay? It's called polymorphism. Okay, guys, don't worry about this question. You will easily understand all these when you are doing your genetics. Okay, so what is the other? So dysplasia, you know it from pathology. What's dysplasia? What's dysplasia? Guys, are you with me? Are you with me? Okay.
Yeah, abnormal cell shape, right? Dysplasia.
Abnormal cellular organization in a tissue. Okay. So what about the other? What is mosaicism?
Right.
I will simply explain this. I will not go into detail. We have mosaicism in Turner syndrome. The example is Some of the cells have 45x and some have 46xx. So the presence of two or more genetically different cell lines within the same individual is called mosaicism. Okay. Normally we have either 45xx or how is that 45xy, right? Either we have this or this, right, guys?
Yes, sir. Yes.
So in Turner syndrome, we have some cells have this genetic makeup and some have this. This is called mosaicism, okay?
So in different individuals or in
In
one,
same
like
individual,
same individual.
same individual, okay?
So it has two different types
Yeah,
of
some
cells.
cells have loss
45x.
of one X, okay?
Yes, that's the X0, right? Like that's the
Yeah,
most
yeah, yeah,
common.
yeah, yeah.
So that
So
could be also
if a
46XX.
if a person have, we simply say that this person have 45XO, but in
Yeah,
genetic study you will learn that all the cells are not like that. Some cells
yeah.
have this pattern,
Other
okay?
one also. Okay,
This,
sir.
that's why we call it mosaicism,
Mosaics.
okay?
Okay.
So what about sequence? So a sequence is if we predict the disease from the previous event or a problem, we can say from the Potters, right? In Potters, what happens? We have decreased amniotic fluid, right? And that fluid is causing all the three problems. Pulmonary hypoplasia, because pulmonary development need fluid, right?
Yeah.
Limbs and facial abnormalities, they also need this fluid for cushioning, right? So if we predict any coming consequence of a disease from a previous event or problem, we can say that is a
Sequence.
sequence, okay?
Okay.
All right. What about association? So we'll study the association. They haven't given that in easy
Yesterday.
example.
Instruction.
They didn't have explained that much easily, but I can say that simply is that association is two or more anomalies. Are you getting my point? Two or more problems
Mm-hmm.
that occurs together more often than would be by chance. Okay?
Mm.
By the way, associations never make sense, just by the way.
Yeah. So it won't be. Yeah, that's a great explanation. Thank you.
Yes,
Thanks for helping me out. Thanks.
yeah, because there's just so ajeeb, like one go in one direction and one goes in the other, and they are
Yeah.
associated.
Yeah. So we'll have a problems of different areas. Okay.
So like an example would be
For
of
example, the Potter
association.
sequence associated with congenital diaphragmatic hernia,
Oh, like that.
like
Okay.
that.
Oh, okay. Okay. Thank you.
Okay. Yeah. Yeah, anyone please. These questions are now easy. We will do it very fast, okay? I have I think I have explained all the concepts, okay? These questions are now very much easy. Just quickly.
After applying the inductive signal to the metanephric blastema, which is the following derivatives will more likely develop.
Yeah,
So, do
sorry.
I need
Sorry
to
to
read the
interrupt.
stem?
Sorry to interrupt. The
Yeah.
whole question is present here.
Yes, exactly. So, ये मैं कह रही थी कि I don't need to read the stem.
Yeah, but if others want to know what's the question, so it would be helpful. But simply they have some
Asking.
research and they are asking about the inductive signal provided to metanephrectlastima from metanephric diverticulum, which of the following adult derivatives would most likely be
Develop.
developed? So what it is? Distal
Distal
convoluted
convoluted
tubules.
tubules. Yeah.
So till distal convoluted tubules, it's one origin, and after that,
It's
it's
ureteric bud. Yeah.
ureteric bud. So all others are from same origin. Calyces, pelvis, collecting ducts, they are
Yes.
all of
Ureteric bud.
ureteric bud.
So do we have another session today, like after this?
Yeah, after this, if you guys are willing to join, we were thinking of doing a session of some questions have been left from pulmomicrobiology. So Dr. Ali will be taking a class.
Okay.
Okay. So
So by the way, like, can we shift the time to a bit early, like the Pakistani Indian time? It's like it gets really late at night.
Yes,
yeah,
exactly. When I texted you regarding
yeah,
like the previous
yeah.
requirement.
We can, but actually we have the other program, right? You guys know that.
Yeah, you told that it
Yeah,
will.
that's
It
the
was last
thing.
one like
Two
last
two
week,
programs
right?
going together.
Sorry.
You told that the marathon classes they will end in the last week only.
Sorry, I don't get your point.
You told that when I texted you like, say, can you please change the timings? And you told me that the marathon classes they are going to end by this week,
Yeah,
and
they
that week was
hopefully,
last week.
yeah, hopefully they will be ending very soon. Yeah.
Okay. So
So we'll
can
be
we
shifting
expect?
to an earlier time.
Yeah.
So we will do a poll in our group because we have students from all over the world, right?
Yeah, that's right.
Yeah.
That might
So
be an issue.
I'm really sorry for that, but we will do a poll. We don't want anyone to suffer. We will do something about it. Okay. Yeah. This question. Anyone, please?
Yeah. Which of the following is most likely to be found during autopsy of the patient? 1 hour boy is the neonatal intensive care unit due to tachypnea and hypoxia. The infant was born at 39 weeks via C-section due to recurrent variable deceleration. Pregnancy was complicated by lack of prenatal care. Infant weighs 3.2 kg. Physical examination shows a flattened nose and bilateral club feet. Breath sounds are markedly diminished bilaterally. The infant is intubated and mechanically ventilated, but oxygen levels do not improve. He dies. What's the autopsy finding? That's pulmonary hypoplasia, Porter sequence.
And
Yes.
it's renal agenesis
Renal agenesis,
It's
right?
Porter's, right?
for a
Yeah,
sequence renal
And
agenesis.
renal agenesis.
yeah, we have discussed congenital diaphragmatic hernia yesterday, right? It causes pulmonary hypoplasia, but it does not cause flattened nose and bilateral club feet, right? You know that, right? What
Yes.
will happen with duodenal atresia and TEF? They will block. It's a simple concept if you think about it. What will happen to the amniotic fluid?
They'll increase polyhydramnios because
Yeah,
the baby cannot drink that. Yeah.
yeah. So, what about surfactant deficiency, ARDS?
Yes.
We have discussed this. It
Yeah.
won't be at 39
39
weeks.
weeks.
So, the lungs are
Mature.
somehow we can exclude that. Okay. So, it's a straightforward question. Okay.
And diaphragmatic hernia can also be excluded on the basis of,
Sorry.
and like what's not the reason of diaphragmatic hernia?
Yeah, the diaphragmatic hernia would cause pulmonary problems, right?
Yeah.
That
But
would be
it won't.
unilateral, no, sir?
Yes, it would be unilateral. You're right. But from the stem, we have flattened nose and bilateral club feet. They don't cause that, right?
Yeah, and that's due to oligohydramnios, renal
Yeah,
agenesis.
great.
So this renal agenesis, are they talking about the horseshoe kidney here?
Sorry, one sec.
No.
One second. What's your question?
Like the horseshoe kidney is seen in Potter's sequence, right? Um,
No,
the is that
that
what this agenesis is, or is it different?
Agenesis
Mm,
mean like no kidneys are not even formed, and there is no urine
no,
formation,
the
right?
we don't have anything related to the horseshoe kidney in the stem. Okay, the
Okay,
horseshoe
so
kidney we will have fused poles. Okay,
yeah,
we
okay,
will have increased risk of infections. We will have the risk of Potter's, right? But not necessarily. Okay, the renal
okay,
agenesis would definitely cause Potter's. Okay, and um, what will be other important points about horseshoe? Inferior mesenteric blockage, right? So the kidneys normally develop in pelvis and it ascends, right? So
mm-hmm.
these are the high yield points about horseshoe kidney, right? It is the
Okay,
problem of metanephric mesenchyme. We will have some picture of fuse poles, right?
pause, yeah,
We will have a question on inferior mesenteric artery. We will have given in this question like recurrent infections, okay, due
okay,
to
mm,
stresses, and the ureters of that would be not anatomically correct, okay. So these
okay,
type of questions we will have on horseshoe kidney, okay,
okay,
and it can lead
okay.
to oligohydramnios, okay,
Hydron base, okay. Thank you,
but
sir.
here they are giving the specific stem for Potter's sequence, okay.
Okay. Yeah, because I saw this the
Yeah,
the
yeah.
the other symptoms were kind of the same. That's why I was wondering how it's different from the other one. The flattened nose and the club feet and all that.
Yeah, all these flattened nose, club feet, and problem with where is it? Breath sound, right?
So
Yeah.
actually, what happens is the amniotic fluid is less. Like the cushion is removed, so we will have like flat features.
Yeah, we have discussed the Potters before, right? What happens
Yeah, yeah.
if so we have decreased amniotic fluid, right?
Mm-hmm.
So if a mother is having decreased amniotic fluid, the reason for decreased amniotic fluid is renal agenesis, right? And how is it causing these problems? The
Because it's
pulmonary development needs normal amniotic fluid first. Okay, so we will have
okay.
pulmonary hypoplasia. The other
Okay.
two problems of flattened nose and face and bilateral club feet, these are because of decreased cushioning. Okay,
Cushioning. Mm.
yeah. So Potter's is very simple. Okay, don't
Okay, sir.
confuse that. Okay,
Okay, sir. Thank you.
no problem. Yeah, anyone please? Anyone please?
This patient most likely has a congenital abnormality related to which of the following structures? So, 7-year-old boy is brought to the clinic for follow-up care. The patient recently completed a course of antibiotic for urinary tract infection caused by E. coli. He has
Okay,
had two febrile.
go on. Sorry.
Okay, he has had two febrile urinary tract infections in the past, both of which resolved following antibiotic therapy. Vital signs are normal. Examinations of the abdomen is unremarkable. Renal ultrasound examination reveals no signs of hydronephrosis. Voiding cystourethrogram shows contrast filling the bladder and extending linearly toward the umbilicus. This patient is most likely has a congenital abnormality related to which of the following structures?
So
It's
what's
the
the problem
urachus.
here?
It's in the urachus.
Yeah,
Yeah, right.
Eurekis.
Yeah. So what's the problem here? We have cystogram, cystourethrogram. We have filling of the bladder, right? Contrast filling of the bladder and going to umbilicus. Okay. Are
Yes,
you
sir.
guys getting this, or we should
Yes.
explain it?
No, sir. It's
No,
good.
I
no. Like,
think
can you please
go.
explain? Yeah, no. Can you
You
please
can
explain?
explain it, sir.
Yeah. So we will quickly explain the other options so you will understand. What is omphalomesenteric duct?
The vitelline duct.
Yeah, and what does it do, or where is it connected?
It's
Umbilicus
the
and the
yolk.
Yeah.
It comes from the yolk sac.
Yeah, and where is it connected?
To the
umbilicus and
intestines, mesentery.
Midgut, right?
Yeah.
So in case of such problems, we will have
stool.
stools, right? Leaking from umbilicus. Okay.
Umbilicus.
These umbilical artery and vein, they are not related that much to the stem, okay?
Hmm.
And same for the ureter and urorectal
Rectal septum.
septum, again between urinary system and rectum. Okay, if you don't know all these septums and all that stuff, by ending the session, you will understand each and every point. But for now, if you don't know, like mesenteric duct, right? So it is connected to mesentery. Okay, rectal. So it is connected to
Rectum.
rectum. Okay, so from general points, you can be able to select the or correct the anatomical questions. They are very, very easy. Just you have to know how to exclude the options. Okay,
Yes,
you
sir.
understand this, right?
Yes, sir. Yes, sir. We can go to next
Yes, sir.
question, sir.
Thank you.
Anyone, please? Anyone, please?
Okay, which of the following is the most likely cause of this patient's finding? A 1-week-old boy is evaluated in the hospital. The patient has been admitted due to urosepsis and is receiving antibiotic uh,
Yeah.
therapy. The mother received no prenatal care. The neonate was born at term via spontaneous vaginal delivery. Vital
Okay.
signs are normal. Examination shows
Mhm.
lower abdominal distension with normal bowel sounds. The
Okay.
penis and scrotum appear normal. Renal
Okay.
ultrasonograph and voiding cytourethral graph reveal a diffusely thickened bladder wall with
Okay.
bladder vesico-urethral reflux and hydronephrosis. Which of the
Okay.
following is the most likely cause of this patient's finding?
So we have diffuse thick bladder wall,
That's
right?
due to posterior urethral valves, right?
Yeah. So we have diffuse thickened bladder wall, bilateral,
Yes.
vesico-uterine reflux, and hydronephrosis. So it is.
Persistence of the urogenital membrane, the posterior urethral
So
valve.
we have explained this, right?
Yes.
If we have a problem over here, so it will be causing bilateral hydronephrosis.
Hydronephrosis.
We have explained this, right?
Yes.
And it increasing pressure over here, okay? And bilateral reflux, okay? So the fluid, the urine will go up. Okay. What is other options? Fusion of bilateral metanephros, horseshoe kidney, right? Guys, are you with me?
Yes, yes, doctor.
Yes, doctor.
Yes, doctor, yes.
Yeah. What about failed obliteration of the allantois? It is urachus. Okay.
Urethra,
We have
uricus.
discussed in previous question. Okay.
Question.
Congenitally short intravesical ureters. We have discussed it's the primary cause of vesico-ureteral reflux. We won't be having diffuse thickened bladder. Okay. It is coming from above, right? So the problem is above. right? We have the problem where problem is here, right? Should I explain it? Sorry, I'm just going very superficially, so it is causing problems. So we have short ureters, right?
Right.
So we have problem in the ureter. It was present in the previous question, okay? So in stem we have diffusely thickened bladder wall. The
Yeah.
problem is from here, right? Or here, right?
Yeah, the
So
bladder.
we have excluded this, right?
This is the Bowman's capsule. The
Are
bladder
you
is.
getting my point?
Yes.
Persistence of urogenital membrane. Okay, this one is the correct one. Stenosis of UPJ. You know about this? So we have three constrictions of ureter. Anatomical, three constrictions of ureter. In the proximal ureter, we have abnormality of uretero-pelvic junction. Okay, if it is stenosed, what we will have?
Nephrosis.
Hydronephrosis. And what do you think, guys? UPJ obstruction is what will be its origin?
It's proximal, up at the.
Ureteric, but would be responsible for it, right?
Mhm.
Yes. Yes. Yes.
Should I explain this? I think you guys are confused. Sorry.
Yeah, because utero-pelvic junctions is like from the pelvis and the ureters,
Yeah.
and so
So we
ureteric.
have we have kidney, right? And we have ureter, okay?
Mhm.
So we have a problem of stenosis of what? This area, right?
Right.
It is called UPJ obstruction. Simple, right? What
Yes.
should be responsible for this? Ureteric,
Uretaric, but
but we call it failure of canalization, okay?
Mm-hmm.
yes.
So the canalization of the tubes are not correct, okay? They are failed, so it leads to stenosis. So what it would cause? It is usually unilateral, okay?
Okay.
So it will cause what? Hydronephrosis.
Mm. Right.
Unilaterally, right? What do we have in our stem? Bilateral
Natural.
vesico-urethral reflux. It does
Mhm.
not have anything to do with vesico-urethral reflux. Okay? It
Mm.
does not have anything to do with the thickened bladder wall. You are getting my point, right? Or should I go into details? I thought it will, the anatomy is very easy. That's
Mm.
why I'm going easy on it, right? Sorry if I have confused you.
No, sir. For me, it's like it's for you. You have cleared it very, very clearly, sir.
Yes,
Okay.
for me too. So clear now.
Okay. So I think we should move on, okay? If anyone have question in this specific question, I think we should explain it. Anyone?
So this urogenital membrane, it's how exactly is this causing this problem?
Yeah.
I didn't
Usually,
quite understand.
Yeah.
sorry.
Let me explain each in some detail so you will get all the questions, okay?
Okay, sir.
Don't worry about it, okay?
Thank you, sir.
So this membrane is present over, this is bladder, this is urethra, okay? So it is present in the posterior urethra.
You,
Okay.
yeah, I got
Okay.
it.
What does it doing? It is
It's probably cushion.
blocking. It is blocking this area. Okay.
If it's
Okay.
Are you getting my point?
Yes, sir. Thank you. Yes.
So this is the anatomical problem. Okay. So
Mm-hmm.
after this, we will have increased force on the bladder because the urine is not passing through. Okay.
Okay.
So the pressure over here will be raised. Okay, so we
Okay.
will have diffusely thickened bladder wall.
Oh, so it's like an obstruction, right? Just
Yeah, great, great. It's an
okay.
obstruction.
I
So
see.
why we will have vesicoureteral reflux and bilateral? So we have here, sorry. So we have what time? So we have here. I'm very poor at drawing, so sorry. So we have
Okay.
ureters. We have ureters, two ureters over here, right? So it is
Mm-hmm.
causing bilateral vesico-ureteral reflux. It is causing the urine backflow in both
That's
ureters.
both ureters. I see. Okay.
Okay. So if the
Okay.
problem, if the problem was somewhere above, so it would be causing unilateral. Okay.
Ah, okay.
Also, the hydronephrosis is bilateral. Okay.
Okay.
Now, let me clarify some the other options so you will understand what is happening in the persistence of urogenital membrane. So, if we have failed obliteration of allantois, we call it
Mm.
urachus. And urachus is the connection between umbilicus and bladder. Okay,
Okay.
so if the urachus is persistent, okay,
Okay.
so we will have urine leaking out from umbilicus. Okay.
Umbilicus. Okay.
What is the fusion of metanephros? So I have told you the metanephros is responsible for forming the
Adult
mesenchyme
kidney.
is
Mhm.
responsible for forming the parenchyma of the kidney, not
Kid-
tubules. Tubules is formed by uro ureteric bud. Okay, so if
Yeah.
they are fused, we call it horseshoe kidney.
Mhm. Mm.
Okay,
Okay, sir.
stenosis of UPJ. Where is UPJ? If we have kidney, if this is our kidney, this is the other kidney. So we have ureter this and this.
Yeah.
So what is UPJ? UPJ obstruction is something is obstructing this part.
Yeah.
So it will cause hydronephrosis, swelling of the kidney, not the swelling of the bladder. Okay,
Yeah.
not
So
increasing.
typically like
Yeah,
stones, right? Stone
yeah,
formation.
great.
Right.
Okay,
Okay. All right, sir. Thank you so much.
so now you guys are clear, right?
Yes, yes, very clear. Thank you.
Okay, no problem. So what we are going to do is, I think we are almost done because, so yeah, you can see the urogenital membrane. This is the membrane, okay?
I see. Hmm.
This is the membrane, okay?
Membrane. Okay.
So it is causing the backflow, okay?
Hmm.
Hydronephrosis,
Okay.
and the bladder wall is due to pressure,
Thickened.
the
Mm-hmm.
bladder wall is thickening. So it's a very simple, straightforward
Simple.
questions. Don't worry, these are just two or three pages from first aid. If you read that, you will be going to pick each and every question very easily. Okay, don't worry
Okay.
about all these concepts. Okay,
Okay, sir.
what's this question? Anyone, please?
Which of the following is most likely cause of the patient umbilical findings? A 2-week-old boy is brought to the clinic by his
Sorry.
parents for
Okay.
evaluation of his umbilicus. The Parents report that since the umbilical cord stump separated 2 days ago, there have been drainage from the umbilicus that increases when the patient cries. He is exclusively breastfed and continues to have normal wet diapers and stool output. The patient was born at term and the pregnancy and delivery were uncomplicated. Vital signs are normal. Physical examination shows clear to pale yellow fluid leaking from the umbilical stump with the mucosal tissue at the base of the umbilicus. Samples are obtained of the CBC and laboratory results are as follows. From the stump, we know that's the urachus, right?
Yeah.
The
So how do we know this?
because the
We
urine
have.
has been coming out from the umbilicus. Yes.
Umbilicus.
Yes. Yeah, so they are straightforward, easy questions. They will confuse you. They will confuse you about the finding, CBC, etc. But at the end, they will simply ask you what is the
Most likely
embryological,
cause.
what is the embryological origin or the cause of the leakage of urine. Okay.
Allantois urachus, yeah.
So remember, allantois is
Elancho.
responsible for making of uricus. Okay.
Yes.
So
Persistence.
persistence of the allantois remnant.
Okay. Yeah, what is this again?
Horseshoe
That's the
kidney.
horseshoe
Hospital
kidney.
kidney,
Yeah, so I have told you we will have recurrent
maternal.
infections. Okay.
Yeah, the
We will
maternal
have risk of
drops.
stones formation. So these are high yield points about horseshoe kidney. This is very visible from the question.
Mm,
Okay. And we
yeah,
have this is formed
Metanephros.
from
metanephrine,
metanephros. What do for mesonephros forming? Wolffian duct. Okay.
bullfrog duct.
So these are, I thought we will be doing it in 1 hour because you will have, because the questions are very simple and easy. Yeah, what's this question?
Big question.
Yeah, let me discuss it, okay? I will read it, okay? So we have 25-year-old, 18-week gestation comes to the office, okay? For routine follow, okay? She reports no concerns and abdominal examinations shows normal height, normal fundal height. So the pregnancy is normal till now, okay?
Okay.
Ultrasound of the fetus shows male sex, okay? The
Mm.
fetus kidney appears fused.
Horseshoe kidney.
Again, horseshoe kidney, okay?
Yeah.
The
Mm-hmm.
reminder of the ultrasound is unremarkable. The couple ask, yeah, and the kidney will be located low, right?
Yeah.
Yeah.
Ultrasound is unremarkable. The couple ask about the implications of the finding and the way they will affect the child after birth. So, in previous question, we have discussed that we will have recurrent infections,
Yeah. C is
right?
the answer. Majority of
Yeah,
patient.
we will have recurrent infections.
Yeah.
We will have increased risk of stone formation. So, the C is saying the majority of the patient will develop developmental anomaly are asymptomatic but would have increased risk of
UTI.
Infection.
UTIs. Okay, should I
Okay.
explain the other options?
Okay, sir.
What do you
Yes.
think, guys?
Okay. Yeah. Good. Yeah. Please do. So that will be helpful in the other questions, hopefully.
Yeah, so what is the first one saying? Many children with this disorder develop kidney dysfunction that goes to end stage renal disease. So, what do you think?
Yes, I was
Mm,
thinking horseshoe kidney has an association with increased risk of renal cancer.
Sorry?
Mm.
Yeah, I read that horseshoe kidney has an association with increased risk of renal CA.
Yes, it
Yeah,
does.
we have
Yes.
that. Yeah, we have that. Yeah, yes, yes. We have
But we do
increased.
not have dysfunctional kidney, no?
Yeah. So the dysfunctional kidney or end-stage
Okay.
renal disease is not the ultimate consequence, we can say, of the horseshoe kidney. Okay. But what is
Oh
the
yeah.
option A saying? What is the problem? A, and I would make it easy for you. The finding are the part of these findings are part of developmental sequence that can lead to impaired lung development and potential RDS.
Yeah. Hmm.
So these two are related because autosomal recessive polycystic kidney disease, we will discuss polycystic kidney disease in other questions, okay? They have decreased renal functions, right?
Yes.
And polycystic kidney disease, we have decreased functions, right?
Yeah.
Mm.
We will have oligo.
Hydromias.
Drum
Okay.
nails.
And these polycystic kidney disease goes to end stage renal disease and have developed kidney dysfunction over decades, or we can say over some time, okay? So they are most likely of referring to polycystic kidney disease, okay? What is D? They are saying it is a developmental sequence that lead to lung impairment and potential
It's
respiratory distress. It is autos, right?
polycystic syndrome.
Yeah. Protestant sequence.
Yeah, what do we have? Increased cerebral aneurysms. I think we have this in autosomal dominant PKD, right?
Yes. Yes, sir.
Yes. Yeah.
And we have varying liver disease, Warren's. This genetic condition is associated with varying liver disease. Yeah, so liver disease, I think
That's
it's
also
in
associated with the polycystic kidney
autosomal recessive, right?
yeah, that causes hepatic cyst and fibrosis.
Yeah, so I think we have done the question enough, right?
Yeah.
Yes,
Yes.
sir. Thank you.
So I think we are almost done because the last 3 or 4 questions are not from anatomy. Okay, let me show you. They are from,
Genetic.
we have, if you see this one, we have chromosome 3p deletion,
Chromosomal abnormalities.
chromosome 3p deletion, and they have given the stem of
Mass,
Cystology reveals malignant cells, so it
renal
is
cell
renal
carcinoma.
cell carcinoma, and we have
That's
mnemonic of 3 for it, right?
VHL, von Hippel-Lindau.
HL.
Yeah.
Yeah, so we will discuss these following MCQ. Don't worry about 2021, 22, and 23. We will discuss it when we were doing the pathology, right?
Hmm.
So this
Okay.
question, let me show you the 21. It's about 8-year-old
Yes.
facial puffiness. So it's about pathology, right?
PSG. Yeah.
Pathology. Yeah.
It's also pathology,
Hmm. Pathology.
and it's
Yeah.
also, so we have done 16 or 17. We have done 17 questions, right?
Mm-hmm.
Yeah.
Yeah, so what's the question 18? So
18.
you guys
Oh,
need
we
to
can do
do
that.
the 18, 19, and 20 yourself, okay? So it is, these are easy questions. You guys can do it, okay? If you want to do it, what do you think, guys? We should do it, or you can do it yourself?
We do
I
it.
We
guess
can do
we
it. We
should
can do it.
discuss.
Yeah. We should
We
do it
can do it
one. Yeah.
ourselves.
I think
We can.
you
Can we
guys
do it?
have another very long class. That's why I'm not bothering you. These are simple questions. So let me do it, okay? Anyone
Okay.
Yeah,
please go through it quickly, okay?
I can. Which of the following will most likely be present in the newborn at delivery? For a 24-year woman comes to the office for prenatal ultrasound, 19 weeks pregnant, based on her last menstrual period, the patient's third pregnancy, and there have been no complications. Family medical history is unremarkable, and both the children are healthy. Examination reveals a male fetus with bilaterally enlarged kidneys with diffuse small cysts. The amniotic fluid volume is very low, no other anomalies are seen following most likely present at birth. So that's recessive kidney disease with Potter sequence, right?
Yeah,
Hmm.
so
With pulmonary hypoplasia.
we have diffuse small cyst, right?
Yes.
And amniotic fluid is
Cerebral.
low, right?
Yeah.
Cerebral aneurysms.
Yeah, so
Polycystic
we have Potter's
Sequence.
sequence. And I've
Pulmonary
told you the cerebral aneurysms are in
autosomal
polycystic
dominant.
autosomal
autosomal
dominant,
dominant.
okay?
Yeah.
So if we have
Mm.
decreased amniotic fluid, we are going
Oh,
towards porters, and porters have.
pulmonary
Pulmonary
hyper
hyperplasia.
pulmonary
So these
hypertension.
are easy questions, right?
Yeah.
Mm.
So what's next?
If
Yeah.
the fetal hydronephrosis is caused by obstruction, which of the following is most likely site? A 34-year-old primary graviда came at 18 weeks of gestation for routine prenatal examination. Patient pregnancy has been uncomplicated. She takes vitamins and her laboratory shows normal to date. Patient personal and family medical history is unremarkable during a visit. Shit.
Yeah.
Don't know where the question got. Sorry, I couldn't see the question. During a visit, a detailed fetal ultrasound examination reveals severe unilateral hydronephrosis. There is no urethral dilation. External genitalia are also visible. If fetal hydronephrosis is caused by obstruction, which of the following is most likely site? You told us that's the UPJ.
Yeah,
Yes,
it's easy question,
UPJ.
right?
Yeah,
So we
Yeah.
have we
UPJ.
have kidney,
Uretropelvic junction.
we have ureter. This here is the problem. That's why it is causing unilateral hydronephrosis, right?
Yes.
If it was below, like over here, some here in the urethra or the bladder, you would have bilateral, right?
Yes.
So uretero-pelvic junction obstruction, right? Why not spinal cord? Spinal cord lesions like spina bifida, we will have which type of
Bilateral.
incontinence? Which type of incontinence?
Overflow
Overflow.
incontinence.
Overflow incontinence. The bladder will be all the time full. It will be causing bilateral hydronephrosis.
Yeah.
Okay. Same for urethra. Like we have discussed, urogenital sinus membrane. If we
Yeah.
have blockage in
Bilateral.
posterior urethra, we call it urogenital
Bilateral.
sinus obstruction.
Yeah.
Same for urinary meatus. Okay.
Mm-hmm.
And what about vesico-urethral junction?
The ureter will be dilated.
That's
Sorry,
Great. We will have dilation.
dilation of ureters.
And
Yeah.
we don't have urethral dilation. So I think it's very easy. What's the other question we have discussed this? So anyone please?
The deletion most likely involves which of the following genes?
Yeah, so
60-year-old man.
sorry. I'm
It's okay,
sorry.
doctor.
I think we have missed one question.
No,
Is
yeah,
it
we
done?
did.
no, we did
This we
it
did,
right.
We
yeah.
did it.
We
We did
Yeah,
that.
so we are almost done with 19 questions. We will do the rest of the 20, 21, 22, and 23 in pathology. Okay.
Okay.
Thank you
Okay.
guys.
Thank you so
Thank you
much,
so
sir.
much.
Thank you so much.
So any
Thanks a lot. It
question
was
about
really
the
good one.
Thank you.
Thank you for
okay.
taking the time to explain all the questions. Thank you so much, sir.
Okay. So you guys understand it somehow, right?
Yes.
Yes, yes, sir.
Yeah, I'm sorry if I didn't make it more clear because I thought it's very easy. So I will try to take some more time. If you don't understand it, okay? Just ask
Okay,
me
sir.
and we will explain it, okay?
Okay,
Okay.
sir. Thank you so
So
much.
if you have something else about program or anything related to your studies, any question,
No.
yes, please.
So, sir, only
Anything.
question is like, so the program is said to be going over the Uworld questions, right? So
Yeah,
Uworld means the real Uworld, right? But why is it
yeah.
not those questions and some other questions from a different website?
So you are saying why are not we doing the original you were right?
Yes, sir, yeah.
Yeah.
Aren't those
So
questions like the standard for USMLE? Like everybody does that
no,
Uworld
let,
papers, right?
let me explain.
Uh-huh.
So the ASUSMLE platform is providing the exact
Mm-hmm.
original UWorld in through
Uh,
their services at low prices. Okay. So
oh,
all the questions we are discussing
That's all the
or
Uworld questions. Yeah, I remember.
are the
What
exact
question?
UWorld questions, okay?
Oh, okay. All right, okay. Then it's okay. I was not sure
Yeah, yeah,
why
yeah.
you're calling it U world and it's not
Yeah,
matching
so
with the real world
it's the
IDs.
yeah, they have done a great job, I think, because they have done the exact interface. They will tell you about the your score, etc. So
Uh-huh.
it's almost like the exact keyword, but I think
Okay.
they are providing it at low price. Okay,
Oh, okay. But the contents are all just the
the
same,
contents
right?
are the same. Okay,
Oh, okay.
don't worry
So,
about it. Okay,
okay, so the knowledge we'll get is the same from
yeah,
that
it's
question.
the same. Okay.
Okay, that's what I was worried about. Okay, so
Mm.
thank you.
Anyone else?
Yes, how about the NBMEs? They mentioned that they
Yeah.
provide
So
NBME.
we have NBMEs from 21 to 31. Okay. So
Okay.
if anyone have completed their studies and wants to check their preparation, how much they have been done, so they can do NBMEs. If they want to do all, it's good. If they want to do some specific, you can go from 25 to 31. Okay.
Okay, how do we
So
get those?
we will provide NBMEs.
Okay.
The most preferable time is after the completion or at the end of the sessions. Okay,
Okay.
so
Okay.
you guys will have been studied all the systems. Okay,
All right. Thank you so
so
much.
the NBMEs will be very good. And the other thing is, we have provided you. We have taken an assessment yesterday, right?
Mm,
So I
not yet.
think
Up
so.
to
I
what
think.
time is it available, sir? The assessment said 48 hours, right? So it's like
Yeah, so it's
uh,
available.
till.
Please don't miss that. It will help you in managing your time. Don't think about the knowledge you have. If you miss some questions, you are in your initial stages of preparation. So uh, don't worry about your score. Okay.
Okay.
Okay. Yeah.
Okay. So guys, I think we have taken.
So
Yeah.
when we do those, sir, they'll track us individually. You'll track our performance individually, like the ones who have already
Yeah.
like uh,
So
joined the group.
we will track all your progress. Okay.
Okay.
So all the assessments record, uh, take it with, maintain it with yourself, and we will also look into your progress. And after some time, we will discuss it with you. We will arrange some sessions that why some of you have a low score and why are not performing. So Dr. Ali and Dr. Imran, and we will discuss with you that you how can you improve yourself. Okay.
Okay.
So we
The
will
Okay.
track
classes will
record.
end in October or November, sir?
So we will try to cover it in 90 days, okay?
Mm,
And for
okay.
that, it's the initial phase we are giving a lot of time, 2 hours, and we have taken the 4 or 5 hours class on Sunday, right? And we are trying to have another class for you of micros. We will cover it. Don't worry. But on your side, it will be very helpful for us if you guys do 5 questions yourself each day. So we will be very easily covering the whole U word. Okay.
Okay.
Thank you
Okay,
guys.
sir.
Thank you guys. Thanks a lot.
Thank
So
you, sir.
we will
Please,
have
I'll be
another
making the
class.
recordings earlier available early. That's something again we need to talk about. Yeah.
Sorry.
For you guys to be making the recordings available early, you know.
Yeah, yeah. We will provide the recordings. Okay.
Okay, good.
So you have another class, okay, of micro. So if you want to take a 10-minute break, so the class will be starts in 10 minutes, okay?
Okay. Thank you.
Okay, sir.
Thank you.
Thank you
Thank
Thank
so
you,
you.
much.
doctor. Thanks a lot.
Thank you so much.
Thank you.
The
Thank
Have
new
a
you.
link
nice.
will be shared for that class.
Sorry?